Hi, everyone. Thank you so much for joining us today for our Health Equity Action Time HEAT 2023 Focus on Mental Health. It's our first session in this next round from our initial HEAT group. And we're really happy that we're able to come together during Mental Health Awareness Month. If we go to the next slide, we just want to start with our land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. We just want to thank all of the members of the HEAT Planning Committee. And with this, I'm going to turn it over to our fearless leader, Anda.
Thank you so much. And just welcome everybody. It's great to see everyone and appreciate everyone joining. So just of the overall goal of 2023 HEAT, we're going to build off what we did together last year, the 2022 HEAT series. And our overall goals for this year is to, one, highlight our progress, and two, identify and address ongoing opportunities and barriers to implementing the critical steps and priorities we had identified last year. And then, of course, take steps and identify steps to take advantage of opportunities and remove those barriers. We decided that the first two webinars of this monthly HEAT series, we thought we would be important to get our brain juices flowing in a case. And we won't be going into depth in anyone's system in the first two webinars. We did want to, one, ground the discussion in a case to highlight the different system resources and limitations for a patient with mental health needs in San Francisco that has applicability to other systems and counties. The second objective is to describe the elements of care program models that facilitate care of a child or adolescent with mental health needs. And then the third objective is to identify some of the ongoing system barriers to providing care for children and adolescents with mental health needs. So how we're going to do this, well, I'll briefly summarize what we did in the 2002 HEAT webinar series, and then present the case to really ground our discussion. And then through that case presentation, we're highlighting system touch points. So for this session, we're going to focus on integrated behavioral health and the managed care plan, care management. And then in June, the other two systems that this case highlights is the school district and our child psychiatry colleagues and resources, in particular the Child Adolescent Psychiatry Portal, or CAP, and have an opportunity to discuss resources and limitations of each system. But again, it's going to be pretty high level. And then in future webinars, we will be able to dive deeper into the different systems. So in brief, in 2022, we had 3-hour webinars for the HEAT series. And our goal was really as a multidisciplinary forum to foster learning, connection, and concrete action to strengthen the system of care for Bay Area children and families and improve the mental health outcomes. From that, if for those of you who participated in the last webinar, we had a picked exercise, which is basically looking at impact and effort and what were the priorities. So the priorities we identified were: 1, building capacity; 2, improving partnerships with communities, including schools; 3, increasing direct services so that we could provide care for children and adolescents who enter our system with mental health needs; 4, provide infrastructure for cross-sector and cross-silo collaboration and information sharing, which is partly one of the goals of this webinar series; And then lastly, scale and sustain integrative behavioral health services. We have a QR code here to the a summary of our HEAT series in 2022, and also in that are links to the recordings. So if you put your camera up to that QR code, it should pop up, and also will be a link in the chat. Okay, so getting to the case. So in early this year in January, in my primary care clinic at San Francisco General, I saw a 13-year-old patient who was new to me. And I could see that he had numerous visits in the past year, but had very inconsistent primary care. So I had never met him before. And when I walked in the room, I just describe, he appeared very quiet. He was almost retracted into his hoodie. He had his hood up. And if you could picture anyone who was almost wanting to be swallowed into himself, that's what he looked like. He had minimal communication, but when he did respond to questions, it was very hard to hear him. He had a low voice, low in pitch and volume, just swallowing his words back in. So it was very hard to understand what he was saying. He came with his mom and his stepdad and they seemed very engaged and eager to help. So we have permission from the patient and the mom to share his journey. And I obviously removed any identifiers, including the initials have nothing to do with him. And I just also wanted to put some context in that we're grounding our discussion in a patient experience as we think through the process of accessing resources to support a patient's mental health needs. And so while there's a lot of variety of confounding medical conditions that may impact his mental health, we're really going to focus on the mental health system. So when I talked to the patient and his mom and stepdad, I asked them what their priorities were for the visit. And they came up with one, he was having leg cramps and missing a lot of school because of them. In addition, as we were conversing, he's also stated that he has significant daytime sleepiness, also contributing to him missing a lot of school. Two, they were worried about his poor attention and requested help with an individualized education plan, or IEP. I could also see in the chart there was a possible history of ADHD, or attention deficit hyperactivity disorder. Three, and I'm not sure they identified this, but it was highlighted for me through the chart and his BMI, or body mass index, was greater than 99%. And he had daily sugar sweetened beverage intake. Also, he had a history of fatty liver. And then lastly, they were worried about that maybe he was depressed. We did a screening of a PHQ-9 in our clinic, and his is 14, which puts him in the moderate category, had no suicidal ideation. And he did state he had been receiving some weekly counseling at school. He also, in this context, mentioned that he was having a lot of trouble sleeping, especially with sleep onset. A little bit about his social history. He's in middle school in San Francisco Unified School District. I was asking about what he liked to do, and he said he plays video games mostly by himself, and he offered that he feels lonely. When I asked about strengths or things that he likes, like what he feels good about himself or what helps him, he thought for a while, had a hard time, but he said, well, he's nice. And he couldn't identify anything he's good at. And in 2018, I could see in the chart, he didn't offer this, that he had moved to San Francisco with a history of interpartner violence in the family. Also, that there was some verbal abuse by a relative around the age of 5, received therapy around that time. He currently lives with a stepfather, as I mentioned, whose language is Spanish, and as I mentioned, they both came to the visit. So one of the first things that enter my mind, like when honestly is like in a situation like that where you have them for first time primary care visit, when I was a little bit panicked, like how am I going to help this patient? in a comprehensive way, and make sure they feel like they're being heard and offered resources. And I also did occur to me that on the spectrum of how patients present with mental health needs, to me, that this seemed moderately severe, even if he was scoring 14 on the PHQ-9, which put him, at the moderate, given everything else, his poor school performance and attendance, his possibly untreated ADHD, and multiple possible confounding other diagnoses, along with depression, like sleep apnea, and also possible PTSD. He seemed like I thought he was reaching specialty mental health, which we'll talk a little bit about in a few slides. So where do I start? Sorry. And the last thing was that the family history, they didn't identify any history of depression in the family. So, so his case touches on system points. We identified what happens. Where does the health plan come in? Also, obviously, an important partner with the school, and then our support from our colleagues in child psychiatry. And so we'll touch on the school and child adolescent psychiatry portal in June. And what we hope to do is have opportunity to discuss, like, what of these system touch points, what are the opportunities and limitations, and facilitators and barriers. So I don't know if you all remember, but last year in 2022, we had spent a year with some wonderful health equity interns working with me, Melody Luo and Mylana Yolanko. They're both graduating from Berkeley's MPH program. So if you have any positions, let me know. But they put together a very comprehensive map. And there's a link and a QR code to it. But it just highlights, I think, so this patient, we're at ZSFG. He's in our outpatient clinic. Screeners, of the screeners, there's a PHQ-9 that was administered amongst other screeners in our clinic. He scored a 14, as I mentioned. Given everything else going on, I was thinking he was in the specialty mental health realm. So I engaged our behavioral health team, who referred to our the county mental health, specialty mental health. There's a waiting list. So in the meantime, he was connected with our integrated behavioral health team, who provided some interim services and tried to get him connected to longer term services. And at the same time, I, as the primary care provider, was also holding his mental health needs in the best way I could until more appropriate services became available as well. So you can see that in this diagram here about how that played out for him. The other things that happened in this first visit is, one, I provided them with a Vanderbilt in Spanish for the parent and also for the teacher. That requires, it was paper, so it requires the family to bring it to the school, which is a very high risk from my perspective, knowing how many papers I lose. I also made the e-referral through Epic to our behavioral health clinician. And I overbooked him in my clinic in 1 week to follow up with me. So I wanted to also just highlight a few things, because some of you may automatically be thinking about differential diagnosis. And in case some other things are nagging, even though we're highlighting the mental health system, I'll just briefly say at this initial visit, he was referred to our Healthy Lifestyles Clinic through Epic, referred for a sleep study, had some baseline labs to look for anemia, thyroid conditions, and non-alcoholic fatty liver disease. And so I could see some facilitators, like it was great to be able to send e-referrals. We have an integrated behavioral health team, and there's some immediate barriers like communication with the school. We have like a sheet that has the current contact information for different schools. So it requires us to find the sheet, call the contact at the school, or email them if possible. There are the paper Vanderbilts. There are also paper release of informations that we're having to give mom for the school and for us. And requires the family shuttling that back and forth. And also just getting timely follow-up. I have, overbooked him into my clinic. And it was very challenging because he's had inconsistent primary care providers. So in that context, I'm going to pass this over to my colleagues in integrated behavioral health, just to give a little bit about what that system touchpoint looks like. So Amy Whittle's with us. She's Associate Medical Director of Integrated Care at Zuckerberg San Francisco General Children's Health Center, and also Jennifer Miller, Director of Behavioral Health Service Line for Benioff Children's Hospital. Thank you, Jennifer.
Starts off, we go to the next.
Yeah, so we're going to break down some of what Anda presented in this case. Some of this is echoing what we covered in the first heat session, but we thought it would be worth reviewing. So Anda was talking about integrated mental health and specialty mental health. So a reminder that in California, we think about mental health services in these two main buckets: the non-specialty mental health care services, or what used to be referred to as mild to moderate, and then specialty mental health care services. So specialty services are administered through the county, and that is something that the state of California decided through their waiver. Some states don't do it this way, and Medi-Cal mental health services are carved into your managed care plan, but in California, they were separate. So it's the county or behavioral health services that are administering that benefit. And then it's the managed care plan, or MCPs, that are managing these mild to moderate, formerly known as, now called non-specialty mental health services. Really importantly, children and youth under age 21 do not require a diagnosis in order to receive any mental health services. And the state has really created this no wrong door policy. So you'll see in that paragraph under the specialty mental health box, it is noting that if a child or youth meets the criteria, they should be receiving, for a specialty, they should be, and I do think this is a typo, I think it should say not receiving any non-specialty services except for when the no wrong door policy applies. So if we could go forward, let me just pause, actually, sorry, can I go back to that? So just to say that the opportunity here for us really is in non-specialty. So we can refer to county behavioral health, but when I say us, I mean primary care. The opportunity is in non-specialty to expand what we're doing. And I will talk about what we're doing at San Francisco General Hospital around integrated care. That's all in the non-specialty category. And we know that referring to county is challenging. We don't have e-referrals to send off patients to all of the specialty mental health providers. You know, thankfully, they are community-based providers, but there's no centralized system to know who has space available or how you could refer to someone. It's really just as manual as picking up the phone and calling. Okay, so now we can go to the next slide that is talking about this no wrong door policy. So while it seems sort of like, well, there's this stark divide between non-specialty and specialty, there is acknowledgement from the state about how blurry those categories can be and how challenging it can be for children and their families to be accessing services. And so if services are provided prior to a diagnosis being determined, while the child is being assessed, and before we even know whether they should qualify for one versus the other, they can have those services be covered and reimbursed. Even if there's not an individual treatment plan in place, those services can take place and get reimbursed. If there's co-occurring mental health and substance use disorder, that person can still have reimbursed services. And you can get both non-specialty mental health services and specialty mental health services concurrently if they're coordinated, not duplicated. So in our clinic, the way this plays out is that you might see our behavioral health clinician, who again is under the non-specialty mental health billing pathway. They then help that person connect to, let's say, La Clínica de la Raza, and they get specialty mental health services. And then that is, that could be covered while there's an overlap period, and the embedded behavioral health clinician in our primary care setting makes sure that that person, you know, is well connected to their specialty services. So next slide, please. And so I mentioned really it's about leaning into this non-specialty mental health benefit. What's really exciting is that there are new codes available under that category that go through the managed care plans that allow for sustainability of integrated care. And we're going to be defining integrated care in a few slides, but I wanted to highlight this center that UCSF has on dyadic care in pediatrics. Also, family therapy is billable under non-specialty mental health, to be either embedded within or not embedded within primary care. But this is where the real opportunity is, and where I think we could see great change when it comes to providing mental health services in a primary care setting. These QR codes will link you to this UCSF Center for Dyadic Care, and also to the mild to moderate or non-specialty mental health provider guide that goes into great detail about these benefits. So the next slide is a review of the qualifications for specialty mental health. So these broadened as of January 2022. And as you can see, the first one is just that the child is at risk for a mental health disorder due to an experience of trauma. And the second being that they have significant impairment or a reasonable probability of deterioration, or they're not progressing appropriately, and they do have a diagnosed mental health disorder. So as you can see, it's written quite broadly to qualify for specialty mental health. At a very practical level, if you go to the next slide, this is a checklist that the state has created to be standardized for all patients seen under Medi-Cal across the state, that allows you to assign points to the patient based on their experiences. So if they've been involved in the past in foster care or the child welfare system, they get a point. But if they're currently involved, then they automatically would be assigned to specialty mental health. If they've ever experienced homelessness, they get a point, but if they're currently experiencing homelessness, then they go to the specialty mental health system, et cetera. So the QR code will take you to this tool if you're interested in exploring it more. Having 6 points or more means that you're qualified to get services through the specialty system. But again, I think the state has really allowed for this no wrong door policy to show that families might be accessing non-specialty mental health services because that's what's available, and that we know that there's going to be barriers to getting all of the kids who would qualify for specialty mental health to a specialty mental health provider. So I will now turn it over to Jennifer to talk about this continuum of care.
Thank you, Amy. So as Amy described, the broadening of the criteria for specialty mental health was put in place to assist with patients and families being referred into specialty mental health with less of a barrier. However, that doesn't change the access to specialty mental health, which is still difficult. And it is still, in some cases, a years-long delay before patients and families can be seen in that system. Additionally, one of the other pieces that's pushing for integrated primary care and behavioral health to become a unified entity is that we want to get on the side of prevention so that ultimately less people need specialty mental health, because it turns out it is in fact a preventable condition in a lot of ways. So what you can see here is a gradation across the board of how integrated behavioral health works. And if you start all the way to the left, the coordinated piece is a little bit closer to what a lot of primary care is set up with now, where they're identifying patients that have behavioral health needs and they refer them out to services. There's been a lot of work on evidence-based screeners to help support PCPs be able to determine more easily what that criteria might be, and also be able to detect certain things more than they were able to previously. They can also have a consultation model where they're able to work with patients to meet the goals. And there's hub and spoke models across the country that arrange with this. But again, it's still referral dependent. It's not quite as easily accessed as when we move more towards the middle, where you have behavioral health care managers that are embedded in the clinics. And an example of this would have been when Anda was doing a lot of that legwork herself to try to resolve the barriers for her patient to be seen or to detect possible services that he would benefit from. This behavioral health care manager system that would be embedded in primary care would pick that up and take it on and hold it to the end, which really is an enormous amount of power put into the system to keep people connected and moving. This is so difficult for patients and families to navigate. It's just as difficult for all of us to navigate when there's not a linking point, and this really assists with that. The next step over is the co-location of behavioral health providers in the same facility. So there's a lot of medical centers where this is the case, where we have primary care and we have behavioral health in the same facility, but they still work in different buildings or different departments, and they see themselves as different entities. And it's only through a lot of legwork and relationship building that they will feel that they can refer back and forth to one another, but they still don't see one another as being on the same team. And that's really important when it comes to integrated care. And fully integrated care is just that, where you have patient-centered medical homes where behavioral health and primary care are together in the office working on one team, and they all own the patients together. So it is a whole person care model, and no one is separated out at any one point. They round together on all the patients. So for instance, if this was the case where Anda was working, they would have had behavioral health in the morning. They could review the patient list. They would have seen this patient coming up, and they could have put together the possibility for Anda to bring in a behavioral health clinician mid-visit while she was meeting with the family, to be able to start the process right then and there, have live consultation and a warm handoff to the clinician. And this is really important because it pushes through the stigma, it builds relationships faster, it reduces fear for patients and families and connecting into behavioral health. And it really will facilitate going forward linkage into care at the level people need it sooner. So we're not waiting until the point of absolute specialty mental health requirement, or where there has been an enormous amount of disruption to the quality of life for people because they haven't been able to receive the care ahead of time when the initial symptoms presented. I will hand it back to Amy for the next piece.
Yeah, so I'll talk about what's happening in our own clinic, the Children's Health Center, which is part of the San Francisco Health Network. We have a primary care behavioral health team. And so the aim is really to be that last category that Jennifer was describing, to be truly integrated. We have behavioral health clinicians in all of the primary care clinics. Our own clinic has 3 behavioral health clinicians with a team supervisor. We also have a behavioral assistant who is charged with doing non-clinical work related to things like referrals to the regional centers and to motivational interviewing about tobacco cessation, more in handoffs for social needs. But really, our behavioral health clinicians are the ones who are there with us. As Jennifer described, they do come to huddle. We do review our patient lists with them to say, you know, I have a feeling that this might be someone that I need to give a warm handoff to you about. They do assist with referrals to specialty mental health when it's appropriate. And they are sustained through billing to the non-specialty mental health system that I mentioned. And this is through our managed care plans. For San Francisco Health Plan, it is Carillon, which used to be Beacon. And you know, the challenge is always just that there are, you know, as I mentioned, 4 people. We have lost a few clinicians, so we now have 2 people for a primary care panel of about 7,500 patients. And because access to specialty is challenged, they do end up holding specialty cases for longer than they should, and it does make it hard to do more of the preventative work that we know would be so valuable. But we feel very grateful that we have the folks that we do within our clinic to partner with us. I was in clinic yesterday. I have a patient who has chronic pain and has had real difficulty attending school for the last 6 months. And she said, oh, I see that she's on your schedule for next week. We booked a concurrent behavioral health session at the same time. Let's strategize ahead of time about how we can really work with this family to take the next steps. So I will turn it back to Jennifer to talk about the UC side of things.
Thank you, Amy. So the ideal for us is to get to the far right side of integrated behavioral health within primary care so that we can actually support our patients out in the front of all of these things. Right now, where we struggle is within payer source. To Amy's point earlier, there's a lot of restrictions back and forth on how we can pay for our services to make them sustainable. There has been some movement in that direction. What is a good example of where a barrier exists for us right now is on our East Bay FQHC. We are not able to use the dyadic billing benefit because FQHCs prevent us from same-day billing. And that's quite frustrating because the entire premise behind that is that we would provide both mental health and primary care in concert with one another. That being said, we do have an integrated team there, similar to what Amy was describing at CSFG, and we intend to expand it for that reason, because it is incredibly beneficial and has a host of other things that will be really helpful for the community that we serve. Payer source across the board with specialty mental health is an issue within the UC system. So our West Bay campus is commercial payer heavy, and on the East Bay, it is Medi-Cal heavy, and they can't be interchangeable at this time. That's quite frustrating. It's frustrating for the clinicians. It's frustrating for the patients and families. It's something that we are working on diligently to alleviate so that there is no longer a barrier to the equity and treatment that our patients are looking to have. The other piece will have to be access. It's been said many times over, we have workforce issues in behavioral health. This limits our ability to take patients on, which really pushes us into this as an integrated behavioral health approach even more important, because as I said before, well, if the system was built and working correctly, we would actually be on the prevention side of the equation. We would be seeing patients before they require specialty mental health to be able to keep them moving forward in a positive way in their lives, as opposed to things having to deteriorate. And then unfortunately now hitting a barrier of we don't have enough clinicians, or that's not a diagnosis we're able to see. There's a host of things in that respect that can get in the way. So right now, our resources are limited is the best way I could sum that up across the board. It doesn't mean that we're just throwing our hands up though. There's a lot of work that we are doing to alleviate that. And CAP is one of the programs that is put in place that has been exceptional in moving the needle on alleviating the access problems and to support our primary care colleagues in being able to take care of the patients and families that they do.
Thank you so much. In the interest of time, we're going to move forward, but we will have we're aiming for the small groups at the end, just to give people a head up. There are small group breakouts at the end to discuss a little bit, and we can dive into some of this more about what Amy and Jennifer just shared in future sessions. There may be ways around with the dyadic benefit, for example, and how at FQHC, at which the Children's Health Center is as well, might be able has been able to get around that. Just as a to summarize some follow-up for this case, in the next 2 months, there were subsequent multiple visits to urgent care and primary care, abdominal pain and nausea, bullying at school, headaches, suicidal ideation, and multiple messages through Epic to me, which is a huge benefit of Epic too. I feel like there's a lot more communication from urgent care to me, and that was concerned about his mental health. I also had learned that school counseling had ended and that he had started service in our clinic as a bridge with our behavioral health team. And you know, my patient and his mom expressed interest in treatment medication, which I also have been able to do in the clinic, thanks to some resources we have in CAP, which we will get to in June. But I wanted to highlight, so one of the multi-sector tables we have is called the Toxic Network Improvement Collaborative, and both health plans are there, which has been so both managed care Medi-Cal health plans are at the table. And I was thinking, oh, we've been working through enhanced care management. I know how to do this. This is a resource. I suddenly had this light bulb like, wait, I should be referring to the health plan care management. And so I looked on San Francisco, he happens to have San Francisco Health Plan. I went on to San Francisco Health Plan's website, found the care management referral contact, reached out, and later, a week later or so, I received a message through Epic, which was just like fireworks went off for me that day in clinic. I couldn't believe there was a community contact. It was in a little tab called Community Messages, and it said, you've been assigned this incredible person you'll get to meet, Vero Hernandez Herrera. And so that care manager, sorry, it says case, but it's really care, reached out via Epic, and then since then reached out to me by phone and email, arranged a meeting with the school, the family, and me. Unfortunately, the family and school did not attend, but that's, that is the reality. Also made a referral to support for families of children with disabilities to help with the IEP. A whole lot of much more coordination with the family and contact with the family came about. But I would like to just turn it over now, just as another touch point in our system that's being highlighted through this case is health plan care management. So I'm really grateful for Vero, who's the lead bilingual care coordinator, who's been so helpful in this particular case, and also Allison Lamb, who's director of health at Anthem Blue Cross. Just to share with us, like, what are the resources, what are the limitations of what health plans offer with regards to care management services?
Thank you, Dr. Kuo. My name is Vero Hernandez Herrera, or Veronica. I am the lead care coordinator for San Francisco Health Plan and trainer as well. And what I want to share with you is the resources as a health plan in regards of care management services. So what we do when we receive a referral from a provider is we get to vet the person, so get to know more about the person using some of the systems, Epic, and also pre-manage to try to learn about our patient that we are getting. Then we will start reaching out to you, the providers, to let you know, as I did with Dr. Kuo, via email or phone by contacting the clinic and let you know that we are the people assigned to you. And this is a very important key piece of our, of you guys' referrals, is for us to start coordinating the care with you, who are the people who are seeing the patient and are noticing some limitations and struggles that the patient or the families are going through. Once we have all that information collected, we will then start outreaching to the patient or to their families. We will assess and the family members, and we will meet them either in person or via phone, whatever they prefer. And then we will complete psychosocial assessments, and then we can identify barriers around basic need, mental health, and if we need to connect them with other community organizations. Now, our program is limited, and that's something that we have a hard time to explain to the patients and sometimes to the providers. We work with a patient in a period of 5 months to up to 9 months. It depends on which program the patient will be open under. And we will then identify if the patient needs a longer care, or a program that will stay with them for a longer period of time, where we can then work on a referral for them in collaboration with you and the family members. Now, for this particular case, I will be in the case for the next well, it's been already almost 3 to 4 months. I will say I will stay for the next 3 to 6 months if we continue to identify that the patient will need extra support, as well as the family. And my goal is that once I close the case, that the patient is connected with the appropriate system of care, and will continue with the services from the primary care physician, at this time, Dr. Kuo, and will provide resources if needed prior to close the case. Thank you.
Thank you so much, Vero. And Allison, would you mind sharing about Anthem Blue Cross's care management?
Sure, and I'm going to go off video because I know it's a little distracting since it's not as smooth. But but hopefully you can all hear me okay. And I'll just piggyback off what Vera was just saying. I mean, on the Anthem side in the care management world, we have very similar structure where we have a dedicated team of pediatric case managers. And then actually most recently, just because we are going towards this more integrated model of care management approach with physical health and behavioral health and this particular population, we've actually reorganized our care management team so that we have the same manager managing both our maternal, child, and youth care management team. So there's a consistency there with supports for not just child, but also family and the supports around that child. And then all like Vera said, I mean, we'll do initial assessments. We'll make sure that we're thorough in the way that we're looking at the holistic needs of our members, partnering obviously very closely with the primary care physicians and others who are involved in that care community. One thing that Vera said that resonates with me is I like to say bridge with our care management team, because where our care managers see themselves as bridges to all the other places in the care community for that particular member and family. And there are times when, you know, things can get lost in translation, especially as we're jumping through multiple systems. I'm sorry, multiple systems. And I like to see our care managers as that bridge to make sure that the member doesn't get lost in the shuffle of the various systems that are involved in providing the lots of wraparound supports. But that can also get very overwhelming for our families, for our members, for our providers, for our community-based organizations who are also in the mix of that care community. So I like to use that lens of the care manager as a bridge. I also echo Vera in terms of the limitations of our care management resources at the health plan level. Really, the goal of our health plan care management is to make sure that our families and our members are on a road towards self-management. And it really depends on the family and the supports that are available to them and the inherent resources that they have. So that period of time that we can support them does vary. But the goal of our care management supports within the health plan is not to be kind of like a lifelong care manager, but really to move them into that journey of a place more towards self-management and to get them the right levels of supports in their local communities to build that for themselves. So I would say that as a limitation, I guess, in terms of the health plan care management side. I also want to point out the factor of data exchange. We're at a place right now where I love to hear that San Francisco Health Plan is plugged into Epic. I know that I'm very jealous on the Anthem end because we do not have that type of interconnectivity at this time, but that is something that is a goal for us within all of the health plan systems, where we recognize the importance of having kind of integrated, coordinated, and also interoperable data exchange, because I think that was the beauty of this story, and that's the power of it. So for us, we're moving in that direction.
Great, thank you both.
Yeah,
thank you so much. I think in the this is a humbling. Every patient I see I learned something. It's a humbling experience, and I'm so grateful for all the different systems that were in place to be able to support this patient. And it still has broken pieces to it, and challenges around communication. And I hope we can figure out smoother communication, if it's through Epic or whatever works, including with the schools, of course. Okay, in the interest of time, we wanted to make sure we had time for people to discuss. I'll turn it over to you, Lauren.
Great, thank you so much. So before we break out, wanted to see if anyone has any brief clarifying questions for any of the speakers. I did see we have a question from Jess Berthed and Petra. Thank you for providing a response to that. And we will have more time to take a look at the CAP program and some of those educational and resource offerings next week in June. And we can certainly mark down that suggestion to look into more. Any other questions for our speakers before we jump into our small group? Okay, so I think we will have breakout rooms set up, and members of the HEAT committee should be in each room moderating. These are the questions to discuss. What are other facilitators you've experienced in coordinating care for patients with moderate to severe mental health needs? What are the ongoing gaps you've experienced? And are there any other additional resources you know of?
Welcome. Sorry about that abrupt transition there. We had some great conversations going on, and Shelley, I captured what you had in the chat. We are almost at time. I assume everyone had as fruitful a conversation. Seems like are we missing a group? Maybe people just dropped off because of the the small group terror, but that's okay because we had some great conversations about school nurses and also leveraging school nurses, MOUs and the MOUs around ROIs, the memorandum of understanding around the release of information. And I just shared with everybody that I just got an email from a colleague of mine who's a pediatrician up in the school health of the state about San Diego having a really interesting program where they sector have a shared ROI. That's so much easier. So I know many of us have been trying to figure that out, and I'm very curious to learn from them. So maybe that's something we can bring into HEAT in the future. And I will share the last screen here. I just appreciate everyone joining us today. And let me just share that where we can have an evaluation and any feedback. We really love to hear from you. It's like 3 questions about like, what do you want to hear more from us? So we'll put the link in the chat, and also in case you like using QR codes. And also that has our HEAT web page on it. So I'll leave that up just so people can take their time getting it, and also it's in the chat. And just want to thank everybody. I look forward to seeing you all. The next session will be on June, hold on a second, sorry. I thought I had a slide on it, but it will be the second Friday of June. So June 9th, 12 to 1. Thanks so much, everyone. Have a wonderful weekend.
Thank you.